Well, thank you so much, Dr. Verghese, for those insightful comments and for really setting us up for our final panelists this morning and emphasizing the patient perspective. This would be Helen Haskell. Helen is the president of the nonprofit patient organization Mother Against Medical Error and Consumers Advancing Patient Safety. She came into these roles after a deeply personal experience, a medical error that resulted in the death of her young son, Louis, in 2000. And Helen has devoted herself to enhancing the patient contribution to safety and quality in healthcare. This has been through raising awareness through a variety of different ways and the involvement and the passage of legislation in her state of South Carolina. We very much appreciate your involvement in this meeting, Helen, and helping us to remember to stay focused on the patient perspective as we talk about diagnostic excellence today. So please, we look forward to your comments now.
Well, thank you, Andy. Well, I just want to talk a little bit. I'm not sure I can match the eloquence of my predecessors here, but I want to talk a little bit about why I'm here, my background, and why I'm interested in sepsis. So my son, Louis, as Andy said, died years ago. What he died from was failure to rescue from sepsis and internal bleeding following elective surgery in the hospital. I was at his bedside the entire time, but I couldn't protect him because I lacked the knowledge of medicine and the knowledge of the hospital that I needed to save him. I accepted with great misgivings the many unfounded reassurances I was given by healthcare professionals. And that's a burden that I will always bear. So I'll talk a little bit about failure to rescue. It's not always looked at as a diagnostic error, but it's one of the deadliest diagnostic errors, and it's a leading cause of death in hospitals, as most of you probably know. Some 10% or more of hospital patients suffer serious adverse events and deterioration, and many of those remain undiagnosed, unrescued, with disastrous consequences. The majority of these patients are septic. And these diagnostic failures continue to occur in spite of numerous advances and safeguards that we've made in the past 20 years, like rapid response teams and a heightened awareness of sepsis in general. And although awareness has certainly increased, essentially the same phenomenon occurs in outpatient clinics and in doctors' offices. So much of this can be attributed to the fragmented, siloed nature of the healthcare system. I talk to a lot of patients. I've talked to thousands of patients at this point, and I hear innumerable reasons for misdiagnosis: flaws in the medical record, flaws in care coordination, the chain of command, test-taking samples, lots more. These things all happen. Cognitive bias, and a tendency on the part of diagnosticians to go with what's familiar rather than to rule out the most serious possibility. That's common. And failure to close the loop so that practitioners know and learn from mistakes is huge. But most often, patients cite a failure to listen deeply. As Dr. Verghese said, to view the patient as a whole, or to respect them as a credible person. Several studies have looked at this as an impediment to accurate diagnosis. Many patients see it as a major impediment, if not the major impediment. And it's not just patients. In much of medicine, there's a chain of disrespect that silences nurses, residents, patients, and families. We desperately need research into the nuts and bolts of how to provide psychological safety so that all these parties can feel safe to speak their minds. But if the key to sepsis is making a timely diagnosis, families are essential to that process. But they have to know what they're looking for. The tools and symptom lists that are generally created for patients now are not always terribly helpful, in my opinion, because they tend to be too general to be specifically diagnostic of sepsis. There are tools available for professionals, particularly nurses, which list things like changes in breathing, changes in appearance, changes in trajectory of the illness, intuitive changes that families can watch for and use without having to take vital sign measurements. Although, I should know, we live in a data-driven world, and people are increasingly monitoring their own health and vital signs with personal equipment and wearables. These are a potential game changer. In short, there's a lot that patients can contribute, but they need to know how to apply it to sepsis in deteriorating patients. So I guess my final word is, if you want to do meaningful research, follow the patients. Find out what the patients and families think went wrong in their missed sepsis diagnoses and what the communication issues were, because they're almost always there. Then find out what it would take to teach families to recognize sepsis, to teach respectful, empathic communication to healthcare providers, and to give nurses and families the confidence to speak up even when they feel uncertain. This is harder than it sounds. But no matter what else you do to improve the diagnosis of sepsis, communication with patients and families is the key that will make it happen. And I'll stop there. Andy, back to you.